Okay, let's get started. It's, well, good morning or good afternoon, depending on what time zone you're in. It's 12 noon now, so we want to get it started on time. My name is Angela Brooks. I'm the Manager of Global Marketing at DISYS, and I'd like to welcome you today to our webinar on top 10 mistakes to avoid in implementing electronic medical records and what to do if you've already made those mistakes. Thank you so much for taking the time today to join our webinar, and we have 3 incredible speakers today to discuss this hot topic. So you're going to learn a lot today. To jumpstart our discussion, I would like to provide some feedback on your responses to the questions that you answered with our registration survey. As you may remember, our first question was, what is your biggest concern in implementing an EMR system for your organization? As you can see, the top concerns were meeting mandate requirements at 38% and training at 26%. Dr. Paula, who is with us today, is going to talk about these points specifically. So I hope you have your pen and paper handy. Also, moving on to our second question, we asked you, at what stage are you in implementing an EMR system for your organization? As you can see, a whopping 50% of you, half of you, are in the assessment phase, and an impressive 29% of you are in the implementation phase already. So today's discussion is going to cover both of these topics in depth, so you'll have plenty of takeaways today to help you move your EMR initiative forward. I would like to discuss, I'd like to formally introduce Shelby Weir, who is with us today. She runs our DISYS healthcare practice, and she has more than 10 years of experience in the healthcare industry and has built client partnerships and strategic relationships with healthcare providers, payers, and consulting firms across the U.S. She's also the founding board member of the Florida chapter of the Healthcare Businesswomen's Association. We're lucky to have Shelby with us today to facilitate the discussion that we're going to have with our presenters, Dr. Richard Paula and James Gaston. Shelby, would you like to say a few words? Oh, sorry, Shelby. Hold on 1 minute. I think you're muted. Okay, sorry, Shelby, go ahead.
Thanks, Angela. I'm very excited to be here, and I'm hoping this is going to be a great discussion today with Dr. Paula and James Gaston. So thanks for hosting this for us.
Yeah, absolutely. Thank you, Shelby. And before I turn the webinar over to Shelby, and she'll be introducing formally our 2 speakers, I would like to let you know that you can ask questions throughout the webinar today using the questions feature in your control panel, which is usually on the right-hand side of your screen. Also, we'll take the questions at the end of the webinar, so just keep them coming throughout, and then we will spend the last 10 or 15 minutes or so, depending on how many questions there are, to make sure that your questions are answered. Also today, I just wanted to let you know that we are recording today's webinar, and we'll send you a link to the recording within the next 24 hours after we close the webinar. So you'll be able to watch this again or share it with others in your organization. So everyone, thanks again for joining us today. We're really glad to have you with us, and thank you too to our presenters. And Shelby, please take it away.
Thanks again, Angela. I want to kick this off by first introducing our 2 very distinguished speakers. Welcome Dr. Paula, the Chief Medical Informatics Officer at Tampa General Hospital. Tampa General is one of the largest hospitals in the state of Florida, and they are a HIMSS level 6 organization. They went from HIMSS level 1 to 6 in 6 months, which is a fantastic effort. They were recently named Best Hospital in the state of Florida by U.S. News and World Report. Dr. Paula spent 12 years as an emergency medical doctor here with Tampa General and moved into the Chief Medical Informatics Officer role. He recently was very instrumental in the implementation of the EPIC electronic medical record. So I want to thank you for joining us, Dr. Paula. Would you like to say a few words?
No, my pleasure, Shelby. I think this is a great opportunity to discuss some important items that are often overlooked. You know, we're being bombarded with messages about the importance of electronic medical records and adapting technology, but there are a lot of landmines when you look forward to your implementation. So this will be a good discussion.
Great. Thank you very much for being here. I would also like to introduce our second speaker, James Gaston. He was recently joining as Senior Director of the Clinical and Business Intelligence of HIMSS and HIMSS Analytics. James has a 20-year career in health information technology and both experience on both the payer side and the provider side. He began his career in Arkansas Children's Hospital, which is the 6th largest pediatric hospital in the U.S., and he was a former Vice President of Medical Office Management Systems, coordinating system support for over 400 physicians' offices. He recently served as the Business Intelligence Leader for Blue Cross Blue Shield of Arkansas, and we are very proud to have him join us. Welcome, and thank you, James, for being here. Would you like to say a few words?
Sure, Shelby. Thank you very much. It's great to be here today, and I'm looking forward to the conversation with the participants.
Great. Thank you so much. So with that, I'll kind of move on to our agenda for today. We, as we spoke earlier, are going to be going through those top 10 mistakes during implementation of electronic medical records. And we're going to take it through planning, assembling your team, determining tools and technologies to use, defining implementation milestones for meaningful use, and then how to properly engage consultancies to help you through that effort. So with that, I'm going to start with Dr. Paula to talk about inadequate planning, and I'll let you kind of roll with it from here.
Sure, Shelby, thank you. Looking at the responses from the survey, I see a lot of you are already doing your assessment and you're evaluating the EMR, and your concerns are fairly typical: time, cost, training, and that's some of the things we're going to talk about. The planning stage for implementing the EMR can start anywhere from 2 to 3 to even 5 years before you actually plug the EMR into your hospital. One of the mistakes that I see made often are the lack of total planning. The planning package has to include everything that you said you were concerned about. How much is this going to cost? What's the time effort? What's the training? And there has to be a very, very detailed project plan, because as you can see from the slide, a lot of the cost is not actually directly from the software or the hardware. 50% of the cost of the projects nationwide are actually from the resources, the human resources you need to make this go live a success. You have to bring in new employees. When you upscale your organization to implement a large-scale EMR, in Tampa General, we almost doubled the size of our IT department, because you're suddenly going from technology being at the side of patient care to the central portion of patient care. So the human costs and the labor are extraordinary. And I think that's a mistake a lot of institutions make, is they underestimate the cost, because the labor, and particularly the contracted labor, no matter how hard you try, you're not going to be able to find enough employees to support your effort. You're going to have to deal with short-term employees either through consultants or temporary labor pools, especially around the go-live time. So this is very, very important. Just keep that in mind, that the labor pool and the contracted labor especially will add up to almost 50% of the cost of your project. Next slide. As part of the planning process, you have to obviously pick a vendor. Now, like I said, I saw a lot of you are in your assessment phase. So when you're assessing a vendor, keep in mind what's happening and what's happened in the recent past in the EMR space. I'll compare it to the cell phone space. Look, 15 years ago when cell phones started to really become popular, how many companies? You could go into any major metropolitan area and there would be 20 companies vying for your business. And over the next 5, 10 years, there was a huge amount of consolidation. Really, right now, how many companies are vying for your business? 4 or 5 at most. We see the same thing happening in the EMR space. Eclipsis and Allscripts just merged. I have a feeling that this is going to continue, and this is borne out by some other industry studies. So when you're evaluating your vendors, ask yourself a question: is this vendor going to be here in 2 or 3 years? Are they the target of a purchase? If they're a public company, are their finances secure? How much money do they have? What's their balance sheet? You need to investigate these companies, because you do not want to be in a situation where you spend a lot of money and then 2 years later you get a note saying, we're discontinuing this product, or we've been purchased and we're no longer going to support. Now, as part of the selection process, when you're actually choosing the vendor, you need to get the medical staff and nursing involved in the selection process very early on. At Tampa General, what some other institutions have done as well, is we sent our medical staff and our nurses on site visits. We had them interact with the nurses and physicians at other hospitals who were actually using the system it's all well and good to rely on organizations like CLASS and other survey organizations, and you outsource your assessment, but nothing beats real conversations at a peer level when you're talking about the product. Now, one of the things when you're evaluating the product is you should be asking about your training. And this is one of the big issues for planning a go-live, is the amount of training. You know, Tampa General, large institutions have 5, 6, 7,000 employees and another 2,000 medical staff. That's 9,000 individuals that are going to require training anywhere from 8 to 24 hours each. That's, you know, it's 100,000 hours of training time. And your physicians are not going to be, you know, filing into the room willingly. You're going to have to work with them and say, listen, this is why this is important. So the training is massive. And then the second part of that training question is not only the dedicated hours of training, but who's going to do that training? So again, we'll go back to the contracted labor, and why you need consultants to help you is that the training itself has to be performed by individuals. And think about the amount of manpower it's going to take to have those tens of thousands of hours of training. Next slide. Okay, so this is where I get to blow my own horn, and not me individually, but my office. And I think the reason you've seen the rise of the CMIO over the last decade is because of where the technology is going. I mentioned earlier, and I firmly believe this is why this is driving this way. Technology has gone from being an ancillary product at the side of patient care. You order a CAT scan, you do something with the computer, to being in the middle of patient care. When you have an EMR or other technology that's intimately involved with patient care, you need to have a physician at a leadership role in the organization that can deal daily with these questions from the IT department about what's going to affect workflow. You know, the other position that is starting to become up and coming is something called the CNIO. It's the Chief Nursing Informatics Officer. And I have a feeling that's something that will be coming also. Because the leadership position will allow you to interact with the physicians on a very high level and take those messages back to your hospital administration and your IT department. Just think what would happen if you let folks who write code lead an implementation of an EMR. It could be a disaster. So the CMIO is that person who is that liaison. And one of their main responsibilities, the next part we're going to talk about, is going to the influential members of the medical staff, going to the chief of staff. In a lot of hospitals, one department is the most influential department because they bring in the most money. Many hospitals, that's orthopedics, cardiology, maybe radiology. Having your CMIO available to have lunch with these individuals, go to their office. You know, really, at times, it's almost like being a politician. But getting that buy-in is extremely important, and part of that is keeping that communication open. You know, listen, Dr. Jones, we are looking at this vendor. I'd really like someone from your department or you to please go on a site visit with us. These are the decisions we have to make. We have to decide if we want to go with vendor A, vendor B. These are the workflows we have to decide. And once you get that buy-in, the next very, very important step is having that buy-in be codified in some fashion in the bylaws. And when you work with the chief of staff and the medical staff officers, it's one thing for them to get them to nod their head and say, we agree. But the second important step is to get them not only to agree, but have them push that agreement and that buy-in into an area where the medical staff is going to have to accept it. And what we did at Tampa General, and we followed the lead from other hospitals, is you put that in the bylaws. So the first step is you get the medical executive committee on board, you get the medical directors to say, listen, we are endorsing this product. If the hospital and the medical staff jointly made a decision to pick a particular vendor, we're going to put in the bylaws, you have to do your training. If you're going to remain on staff at this hospital, you have to do your training. This is an important tool, and it's dangerous to use it without the training. And then when the training is complete, maybe there's post-assessment competency issues, maybe there's ongoing training. This is extremely important because once the medical staff sees that the leadership of the medical staff agrees and endorses the product to the point where it's in the bylaws, it really makes a huge statement of collaboration between the medical staff and the hospital, and the physicians don't feel that this is being done to them. This is a communicated effort that is done as a collaborative project. And that's very important. Physicians right now are being bombarded on all sides with a lot of negative news about medicine, about their profession. So this is one more reason for them to become frustrated. So engage them early, go to leadership, Get the bylaws to codify your discussions and your buy-in, and that will really make your engagement with the physicians that much more fruitful. Next slide. So the team that you're going to use to implement the EMR is composed of individuals. You can have as many computers and the best software that you want, but unless you have individuals in those key roles, unless you have someone that's a real rock star with testing, or someone that knows an application extremely well, you're going to fail. So find individuals in your organization. You can either go outside or find the ones in your organization that are already top performers and train them. Send them to the headquarters of your EMR vendor. Get them trained. Give them a reason to stay at your institution. And you need to do that amongst the different departments and get the right individuals. At Tampa General, we took folks from internal departments and brought them into IT. On our application teams for all the different modules of our EMR, we have folks that came from operations and then got trained in IT and in the particular vendor that we used. And now they're still with us because they were loyal to the organization beforehand. They acquired the skill set and they stayed because turnover is a real big problem. So when you're looking at the different skill sets, you want to make sure you consider what's up there on the screen. Reporting is a huge deal. I mean, the reason you buy an EMR is to get the reports out, not only for regulatory reasons like meaningful use, core measures, but to do your business intelligence, and James is going to talk about this later. What do you need to run your business? And that's reports. And what do you need to do to put the EMR in? You have to develop interfaces and testing, and then finally, it's the support. Now, the thing I can't stress the most, and probably the most important part of this entire discussion, is the support. Support before the go-live in terms of the build, the post-go-live support involving the help desk, but also the overall general support that you provide, nurses, physicians, and ancillary staff. Next slide. So we just discussed reports. One of the issues I have seen firsthand and other hospitals have witnessed is a very difficult time with reports. When you get a vendor in your office in front of your board, they have very slick presentations. They will demonstrate tools that can bring up everything that you think you need to run your organization. They'll look at operating room turnaround times, emergency room throughput. They'll say, you hit this button, out comes this beautiful report that's canned, it's already built, and it'll just be amazing. What they don't tell you is everything that has to go into making those reports not only work, but to make them transparent so the physicians and the folks in operations will believe them. And even small, minor modifications in your build dramatically affect whether those reports are going to run. You know, when you get the vendor, they come out and they show you those reports function based on a completely what's called a model system, or a system that has no modifications. Well, if your hospital system is anything like mine, you are going to make modifications that are based on your particular workflows. And even small, minor modifications in those workflows are going to cause an issue with the reports later. They either won't run, or they'll come out looking so funky that no one's going to believe them. So spend the time early to validate these reports. And we talk about validating them. You have reports team members that you employ, that you train, that really get to know that EMR very, very well. But what they may not know is the workflows that are necessary to have particular data stamps or time points that go into those reports. And I'll give you a perfect example. We developed a report for our emergency room. And we ran it, it looked great, and we looked at a particular metric. It was triage time. So the triage time is when the patient is seen by the nurse, supposedly before they're seen by the physician. They ask them a set of questions, they do their vital signs, they determine how sick they are. So we ran the report, and our triage time was hundreds of minutes. So we sat in this room, we're wondering what was going on. Well, and then it turned out that some of the patients did not get triaged until after they were already seen by the physician. They would be brought right back to see a physician, and the nurse wouldn't appear to triage them until 30 minutes later, so while their care was going on. So we had to go back and look at the workflow literally step by step by step, by minute by minute by minute, and say, okay, if the patient comes in, what happens if they don't get seen by the nurse right away? how does that change what we're going to report on? Well, it changed it a lot because your triage time that was being reported was not accurately reflecting what was going on with the patient care. So that is huge. You have to really make sure, and that's just one example. Our OR turnaround times, all those things, they have to reflect the workflow. So your physicians and your operations folks, they have to believe that these reports are accurate. So that triage example I just gave you, what did that do? That caused a giant uproar in our ER management meeting because now the report wasn't right. What does that make people think? It makes them think that the rest of the reports that you're presenting are not accurate either. Once you lose the confidence of your physicians and the folks that are trying to run your business, you have a problem. So go back to the original point we were just making about the reports. Validation is critical. So the accuracy is determined by where these data points are coming from. And with the triage example, we have to go and do step by step by step to really look back and say, why is this report wrong? And it took weeks to fix these reports. A number of them had very small differences in what we thought the data showed with what it actually showed. And sometimes it comes down to a matter of opinion. If you ask a doctor a question about a particular data point, you may get a different answer when you get a nurse. You know, an example, when does care of the patient start? Well, the doctor might say, well, care of the patient starts when I start ordering on the patient. And CMS may say, no, the care starts when you actually touch the patient. Or the care starts when you're in the room or when you start documenting. So some of these issues are matters of debate, and they have to be put out there, and everyone has to agree, because that can ruin your reports, is the difficulty in getting buy-in and getting validation from the consumers of these reports. And I'll tell you, that'll make a huge problem when you're trying to run your business. Get those reports right, get the validation done, and then go, and then you run your business.
I think this is a great topic, too, for James to weigh in on here. Can you give us, James, some recommendations around business intelligence and reporting?
Certainly, I'd be happy to. Thank you. So, as Dr. Paula mentioned, clinical and business intelligence is a key part of why you put in an EMR. And there's some findings that HIMSS Analytics recently came out with on best case practices around implementing clinical intelligence and business intelligence. You can find a complete white paper sponsored by Oracle on clinical and business intelligence survey at our website, and I believe the link for that is at the bottom of the slide there. But the recommendations that came out at the end of the paper are summarized here on this slide. One is that it should be clinical and business intelligence to be positioned to support and enable your organization's mission and vision. And I know that sounds hokey, and a lot of people talk about mission and vision, but the point is, if you don't have buy-in from senior level management and their support all the way down through the rank and file, then you're not going to have the resources you need, as was noted earlier, or the support you need to work through these issues and make sure that they produce positive results for your organization. Second or third here, clinical and business intelligence is an active and engaging process. It's not a technology. It's not an application solution. It's not something that you can go buy, plug it in, and the IT department worries about it, and everything is taken care of by, technical staff. Clinical and business intelligence is something that all staff have to engage in. Just as Dr. Paula mentioned, you have to have people agree on definitions. You have to have them agree on findings, and that produces results through your systems and your applications that help your organization function. Two, and Dr. Paula mentioned this one also, you want to make sure your physician leadership is involved and engaged and understands the capabilities of clinical and business intelligence and is actively using and pushing those capabilities. Common language is just what we were talking about. How do you define when a physician engages with a patient? That's an example of managing metadata and data governance, where you establish those standards across your organization, and that's very important. And then finally, one of the key findings that we found was that you have to gain and maintain support of your key stakeholders and your customers. You can't put in these systems, put in these reports run, and that's all there is to it. And they don't need to evolve. They have to evolve. You have to listen to what the nurses are saying or what your staff are saying or issues or problems, and address those issues. Make sure you have the support of the folks who are using these tools and listen to them and make changes and move forward with your process. So I hope that was helpful. And I hand it back to Dr. Paula.
Thank you, James.
So definitely check out that link. HIMSS has been very helpful to me personally and to organizations. They do a lot of research, which can be extremely helpful.
Next slide, please, Angela.
Okay, we'll start with that little floating bullet there. One of the reasons we chose our EMR vendor is because we wanted to replace a number of disparate systems. I believe the number was 37 or 38. When we put our EMR in, we were able to retire or decommission 38 separate systems. Now that sounds fantastic, and it was. Saves you a lot of time and money, but what it didn't do was replace all the systems. So we still ended up with over 50 interfaces with our EMR. Now, every interface takes time and effort to make work correctly. Again, this is another area where your vendor will come in and give you an excellent sales pitch. Oh, we interface with this, we interface with that. We're at 3 other hospitals, we've already interfaced with that. What they don't tell you is every interface is different because of the version of the system you're on. And every interface that you add increases the complexity because the interfaces might not only interface with one part of the EMR, it might be on multiple levels, and they might interface with each other. And typical examples of this are the lab system. Many of the EMRs you purchase today do not have lab modules, or if they do, they have not been around for a long enough time to establish a track record that you can count on. We have at Tampa General, we have SunQuest, and we had a lot of issues doing the interface between the lab and the EMR, mainly because we have tens of thousands of orders every month, and so we had to run a huge amount of interface testing and build the interfaces. The other things that you look at that hospitals have to interface, back-end coding systems. Most EMRs do not have coding systems. Most hospitals rely on companies like 3M, and there are a couple other vendors out there, and these have to interface. And again, the interfaces are dependent on individuals building them, maintaining them, and then you have the end users that have to not only know how to use the system that's being interfaced, but also use the EMR. And this can become an issue because systems like coding are driving the revenue for the hospital. So if these interfaces are not working correctly, you have a huge problem. And same thing with the lab registration. A lot of EMRs do not have front-end registration capabilities. You have to build an interface there. And what happens if the interface is not working correctly? You have an issue with your demographics, and that's a huge patient safety issue. If dates of birth get mixed up or medical record numbers or social security numbers, I think you're getting the point that I'm trying to make, that these interfaces are large. They require very specialized talent to build and maintain, and they aren't going away anytime soon. As much as I'd like to have an EMR that encompasses everything, I do not believe in the foreseeable future there's an EMR that's going to take over all your systems. Now, when you're looking at the interfaces, besides the actual feed that you're building, which is a technical issue, what are the workflows behind those interfaces? It's sort of like the reports area. Where does this feed into? Is it multiple levels of the EMR? Are we trying to use what we have, or are we trying to use the capabilities of the EMR? One perfect example is pharmacy. A lot of EMRs have pharmacy components, but the pharmacy component does not actually dispense the drugs. There is a huge installed base of Pyxis workstations. Those Pyxis workstations have to interface directly with the EMR, and directly with the orders component of that EMR. So again, multiple interfaces that have to be built. And then what you have to do after you build these interfaces, you have to test them. And I think the implementation of an EMR can live or die on testing. And that'll bring us to the next slide. So specialized testing. So one of the things I was just discussing was interfaces. So the interfaces themselves, besides being built, take a huge amount of testing. Because you have to look at every interface, where it goes. And I love this graphic that's on there. This reminds me of what our testers were doing when I walked into their room. At Tampa General here, we had a room where we had maybe 12 or 16 individuals for 12 hours a day doing nothing but testing. And there was all sorts of stuff on the whiteboards, technical issues that I couldn't begin to describe. But the point is, every one of those individuals had a responsibility for any number of interfaces, any number of workflows. So there is a framework to testing that really needs to be followed. And unfortunately, there is a scarcity of individuals who know how to test in this environment. Because the EMR implementations have been rolling across the country, all these huge hospitals are doing them. I don't think there's any large hospital system that has not either put an EMR in recently or is doing one soon to be. So these individuals are very scarce. A lot of them went to work for consulting agencies. They move around. You have to find them. You have to bring them in, get folks that have experience, find individuals that have worked with your particular EMR vendor before, and then get a couple of your own individual employees and attach them at the hip so they can siphon off that knowledge. So when your consultant leaves, you're not going to have a problem. Now, when you start discussing with your consulting agencies about the different types of testing, make sure that they know how to test in multiple different stages. Just a quick definition there, integration testing and regression testing. So the integration testing validates that your interfaces are working. So the long lines, the pipes of data that are feeding, sometimes bidirectionally, those are on, those are working. Well, that's only step one. The harder aspect is the regression testing. The regression testing is something you need to do not only before go live, during go live, but you will have to do every time you make even a minor modification to the system. The beauty of these EMRs, as I discussed earlier, is that you can replace multiple systems with one platform. That's also the curse. Because you have one platform that extends its tentacles over multiple areas of patient care, you may not realize that changing a small cell someplace and where data is entered, or changing the build in a very slight fashion in a nursing workflow will have downstream effects to physician workflow, pharmacy, and have patient safety implications. You need to follow those items that are being changed, and that's regression testing. And that is much more difficult than integration testing, and it's much more widespread. And the folks that know regression testing well for your particular vendor are going to be hard to find, and you need to find them early. Now, the last part about testing that we need to really talk about, one of the things that CIOs and CMIOs say is that the two things that will wreck your reputation or organization are passwords and printers. So you need to do real-world dynamic use testing. You can't just be in a room, have the printer there, and say, oh, it's working. Because those of you that have been through this before realize things will work in small, confined spaces, but when they're out there on the floors and you're trying to do things like print labels, print prescriptions, print the normal paper, print the counterfeit-proof particular prescription paper, you have to test all those individually. And I know at Tampa General we had almost 1,000 printers here. We had to go, and every single one of them had to be tested individually, and that took weeks. Next slide. So going from the testing environment into the go-live support. Going up to go-live, we went through, we tested the interfaces, we tested everything, all the printers are working. Well, I can tell you, everything you think worked correctly before go-live won't work when you have your go-live. And this is because the things that you supposed were going to happen don't. And a lot of this goes back to human behavior. Physicians, nurses are hardworking, dedicated, intelligent, sympathetic individuals. But they often become set in their ways. And asking an established physician to change completely the way they do things is very difficult to expect without a lot of frustration on their part and on your part. So you need to make sure that when you're looking at your Go Live support, that it's not just individuals that understand your particular system. It's individuals that can be emotionally intelligent, that know that workflow changes are there, and know how to deal with angry individuals who don't want to deal with those changes in their workflow. They need to be out there at the elbow, interfacing with doctors and nurses, getting yelled at. They need to know that these workflows are there, and they need to be expert in the different workflows. The ultimate goal is to transition the support from at the bedside to a help desk with some occasional mobile support. But that takes a large amount of resources and a large amount of training. We'll talk about, in particular, one way to get that training and get that support in a very short fashion, and that is with some temporary labor. One thing we did at Tampa General, we engaged with a local short-term staffing agency to find individuals that we could train quickly, that already had a knowledge of medical vernacular. Many were students, nursing students, radiology tech students, and quickly get them up to speed on both EMR and the workflow. And we did this in a way that was really financially viable for our training effort. We were able to get 50, 60 individuals at a much better price point than if we had used very high-paid expert consultants. So I really recommend looking at a model where you can engage agencies to help you find individuals that you can train personally that will allow you to have more individuals out in the field, so to speak, but at a much better price point. And then you supplement them with expert consultants that will help you with the training and help you with the support. And then you'd be surprised, as you start to peel off your individuals to go live, you might end up hiring some of these folks like we did. You know, of the team of 50, we hired 5 very bright, super energetic individuals that are still here a year after the go live. We're really happy about that. So one of the areas you need to pay particular attention to with the support are your high volume, high turnover areas. And by turnover, it's not employee turnover. Turnover means turnover like in a restaurant where the tables are getting turned over. So the GE Center, cardiac cath labs, and the outpatient OR, our GE lab does hundreds of scopes a day. We have 10 rooms. They are in and out of there in a very systematic fashion. That is a lot of revenue for the hospital. These are highly motivated individuals running these centers. A lot of them have business training because, you know, the MBAs out there want to go in an area where their training is going to help. And when you have these organized, structured areas in the hospital, they're going to want to make sure that they're efficient. So you need to pay particular attention to them, otherwise your revenue is going to suffer, and some of your most highly motivated individuals in the hospital are going to suffer. Cardiac cath labs, exactly the same. Again, motivated individuals, they get them in there quickly, they do their procedures, and they get them out. Outpatient OR, many hospitals have large outpatient operating theaters. Again, they get them in, they get them out. These patients do not stay in the hospital, and even 10 minutes extra in the recovery area will prevent the next case from going in. So when you're looking at your support for Go Live, you need to put more individuals in those turnover areas. Eventually, you would like to support your physicians and your nurses with a help desk, because you're not going to have the money to have the dozens of individuals floating around the hospital doing live support. But let me tell you, when you have a help desk that supports an EMR, they're not just doing password resets. The old model of having a barely high school educated individual on the telephone making $12 an hour is gone. It's finished. If you expect someone like that to be able to have a deep knowledge of workflows, of an EMR, you're going to be in trouble. So you need to structure your help desk where you're going to be providing most of the support over the telephone or over web chat or some remote system. And you can allow for some mobile support where you can have individuals that are really having trouble. You could dispatch someone on a timely fashion, or you could have a system like we do at Tampa General where you make appointments. If someone's having trouble, they'll see them the next day at 7 o'clock in the morning. But you need those help desk individuals to really have a higher clinical understanding, because a nurse or a physician is going to call, not because there's a technical issue. I mean, they may. You still have to do the password resets and, I can't get into the system. But what are the calls going to be? The calls are going to be, I don't know how to order this. A help desk person has to know what is the difference between ordering an x-ray and ordering a medication, ordering a procedure. That's not just something that you can, find with a high school education. You need someone that, if they are educated on the high school level, you're going to have to bring them in, and you're going to have to give them a fair amount of training. You can't just expect them coming off the street at the current structure of the help desk. And these training requirements are going to be much more than your physicians and nurses, because they're going to have to know workflows across the board. They may get calls from respiratory therapy, they may get calls from nursing, from physicians, from registration. So your help desk individuals have to know the entire system. The folks that train doctors and nurses only have to know one aspect. Your help desk folks are probably going to know the system better than anything. And as you can see with the little graphic there, getting individuals like nursing students to help you man these help desks is very important. We did this at Tampa General. We found folks that were at the medical academies. We brought them in. These were individuals that were looking to get careers in being a radiology tech or a pharmacy tech, and we brought them in as help desk support, and they've worked out really well because they already had the wherewithal to get into these academies to start looking at their careers. Now, this clinical environment also requires that you're going to have to pay them more. I'll go back to my original discussion about having help desk individuals that are more educated than they were in the past. You can't expect to just pay them what you were paying help desk folks 5 or 7 years ago for doing password resets. And be careful, because once you train them, they're going to get called by consulting companies and other institutions. So this is a big deal. Get some individuals from inside your organization, train them well, and put them on your help desk.
I think that's a really good point. And we've had this experience here as well at DISYS, where we've staffed up help desks for hospitals and providers in the Midwest, and we utilized nursing students and such. And obviously, in the beginning of the go live, like as you mentioned, Dr. Paula, there is a large number of calls. So you need some, additional staff to kind of handle those overflow calls. And then as that moves downward, you can rely on your consistent staff.
Mistake number 8, using the wrong tools and technologies. Again, this is something I've seen borne out at many hospitals, and now including our own. When you're looking at buying hardware, one of the first things you look at is cost. And the cost of fixed workstations is significantly less than mobile workstations. But I can tell you that the demand is exactly inverse of that. We had a situation, I'll just give you an example of what happened at HITECH. After our go live, the rovers, they used to be called cows, but has some pejorative term to it, so we renamed them rovers. The rovers were commandeered by our nurses. They taped pieces of paper with their name on them so the physicians could not borrow them. Then we looked at the analysis of what devices were being used, and all the money we spent on our devices that are in hallways and in fixed areas are being used much, much less than the rovers. And what happened after that, there wasn't enough rovers, so we ended up having to go out and buy some more. We did find an alternative. There's different levels of mobile technology. There is the full functioning rover, which you see a lot of at HIMSS with the drawers and the wheels. There's also the laptop on a stick, which is a much more cost-effective way to get mobile tech out to your providers. And then the physicians, not being even satisfied with that, started bringing their own devices. And this is an opportunity to engage your physicians even more. What we did is we anticipated this was going to happen. So we said, how can we engage our physicians with their mobile devices? A lot of EMRs have applications that are specific to the iPad, the Android, so we immediately deployed those. We also enabled the Citrix application, both with Android and iOS, that let the physicians remotely dial into the EMR, and that was a big winner. If you want to really engage your medical staff, get your mobile strategy out in front, even when you're selecting your vendor. Ask your vendor, What are your applications you have for mobile remote work? Are they Citrix-based? Are they unique applications? Can you order? Can you see labs? Can you e-prescribe from your device? Those are all things you should ask when you're doing your vendor selection, because it really will pay off. And then when you're discussing the hardware, once again, bring your physicians on board. Engage them. We had a device fair. We had the doctors come in and the nurses. They played with them. They typed on them. We tested their battery life, because the battery life is a huge issue. You will have a vendor, just like they did with the software, come in and say, this battery will last 8 hours. Well, it's 8 hours if it is used in the way that they describe, which in a healthcare setting, which is often chaotic, is impossible. That means you have to charge it for 6 hours, take it off only at the end of that 6 hours, and then use it continuously on for 8 hours, which in real-world testing and environments does not happen. So your battery life is going to be considerably less, and that'll just increase the amount of devices you have to buy. So keep that in mind. And I think the next slide, we're going to go to James, and he can talk about some of the hardware issues.
Yeah, are we on the next slide there?
We are, James.
Okay, I thought we were going to 17.
Yeah.
Oh, well, mine's stuck on 16. One of the things that Dr. Paula mentioned earlier was Tampa General going from a stage 1 to a stage 6 hospital, or NRAM stage 1 to NRAM stage 6. NRAM, or electronic medical records and ambulatory model, is a classification that a lot of hospitals use to sort of gauge where they are in their maturity with deployment of healthcare information technology. So stage 1 hospitals are beginning in the adoption model, and stage 6 and stage 7 hospitals are much more mature in the adoption model. And I think one of the things that you've probably picked up on in the commentary so far in this conversation is that there's a lot of active participation required in the later stages. So when you deploy an EMR, you have to engage your staff, everything from your help desk all the way through your executives. And in the healthcare world, I worked in a hospital for 10 years, and years ago, and even in the recent past, if you deployed an application or a device such as, what we used to call them cows, or PCs at the nurse's station in the units, you deployed them, everybody got trained, and they were very static for a long time. But now what we're seeing is that the environment where those devices are being used and where the technology is being applied is dynamic. So we're moving from static environments with static technology and static demands. The report comes out, it's the report we've always had, there's nothing that's going to change, to, well, now I need that report, but it also drives another report, and that drives part of my care process, and it has to adapt as my care process matures or changes or evolves. So the challenge is, and what you want to pay close attention to, is creating an infrastructure and an attitude where you can excel at being dynamic and having a dynamic environment that supports, the devices that we have today. Everybody knows that the mobile phone they have today is only going to be good for a year or two, and the mobile phones that come out next year are going to be much better than the ones they are today. So you have to plan for that obsolescence and plan for that change and that maturation, that migration of the applications, of the skill sets, of the care process, and of the technology.
Great, thank you, James. Next slide, Angela. Mistake number 9. Now, this is another area many of you were concerned about. Tampa General just recently attested for meaningful use this past June, and I can tell you unequivocally that in large hospitals especially, this needs a full-time individual. You need a project planner who is going to be able to corral all the resources necessary to make this happen. You can't just assign it as a part-time job, especially if you have a large institution. You'll get these vendors saying, we're meaningful use ready. We have been certified. We have this hospital that's attested. You'll be ready to go right out of the box. What they don't tell you is, yes, you need this FTE like we just discussed, but, oh, hey, those meaningful use reports, those are extra. They're not part of the original application. You need to pay X amount of dollars. Again, ask that of your vendor. Are the meaningful use reports included in the price? Are they pre-built? And I'm not going to go into the whole question about validation, but again, you need to make sure that you validate those meaningful use reports. There are a number of objectives that are very easy out of the box. Getting your vital signs in, making sure labs are discrete. Those are things that 99% of all the vendors will do right out of the box. But there are a number that are extremely hard because the flow is not automated, and it comes down to human behavior. You have to look at data point A, data point B, and data point C, and you have to have a workflow that they're actually going to follow so you can not only will the report be accurate, but you'll meet the measure. And this comes down to nursing, med staff, registration. All the parties involved have to agree where a particular workflow is going to occur. A perfect example for that is some of the quality reports about venous thromboembolism. Where does that get documented? Does the nurse document it? Does the physician document it? How many times is it documented? Does it have to be inside the physician's note? Can it be structured data from the nurse? Those are all things that your vendor is not going to be able to tell you. It's a specific institutional decision. So with meaningful use especially, when you look at those reports, realize what has to happen. And again, I'll plug the need for a CMIO. This is another area where a high-functioning CMO in a leadership position can work with the different stakeholders, the physician leadership, the nursing leadership, to oftentimes lead negotiations between where these data elements are going to lie in the system. Before those reports are ready, before you can attest, all of those data elements have to be agreed upon and they have to be acted upon. And then, guess what? You have to train all the individuals involved on how to make this happen. Think about this before you go live, build it into the training curriculum, and then make sure that everyone agrees. And you can see by the final line there, this is not easy. The government said, here's the meaningful use metrics, and look what's happened. Only about a fifth of the hospitals, that's 1,000 out of 5,000, have attested in March this year. That means that there is a lot of money being left on the table because if you don't attest by the end of this year, you're not going to be eligible for the full amount of money. The reason is it's not nearly as easy as it's made out to be. Think about this when you're selecting your vendor. Think about it during build. Think about it with medical staff engagement. All right, next slide. Finally, mistake number 10. I think throughout this presentation, one of the things we've emphasized is that you need highly qualified individuals. I do not believe in the current environment this is possible without engaging consultants. And I'm not saying that because this is a DISYS presentation. I'm saying that because there are so many instances where you need experts, testing, training, go-live support, that it will literally be impossible for you to find them on the open market. You can't. And the other point is that you don't always want a full-time employee in these positions. When you have to train a couple of thousand individuals, you don't want to hire the full training team of 25 because what are you going to do with them after the training is complete? Sure, you'll have some ongoing training, but you're not going to need 25 full-time employees. Better to engage consultants who are experts at training with your particular EMR, have done it in other places, and then when your go-live is done, you keep 2 or 3 of the trainers who have hung around with those consultants, taken some of that knowledge, and can apply it on an ongoing basis. The consultants need to know the healthcare environment. you preferably should choose those that have worked with your particular vendor. Some consultants will say they're experts in Epic or Cerner or Meditech. Find ones that have done implementations with your particular vendor. That's vital, because the EMR has very specific workflows, and it's essential that that consultant knows those workflows. Again, they should be credentialed, they should be skilled. There are a number of nurses and physicians out there in the market that can be extremely helpful. And I think that concludes our webinar. If you want to go to the next slide, we can talk about our summary. Plan adequately, gather and align dedicated resources way before you go live. Make sure you engage the medical staff, hire a CMIO, get them early, get their buy-in, take their buy-in, codify it in the bylaws of the hospital rules and regs. Assemble an effective team. Find consultants, hire individuals internally, get them trained, find individuals that you would like to stay on, and keep them happy. Build and validate your reports. This is a piece we have to emphasize. Reports are an underestimated work effort. What you see, what the vendor shows you, are only really the surface of what needs to be done in reports. You need to remember to make sure they will need to be validated. Dedicate resources to doing that validation. Interfaces and testing. Interfaces will not go away no matter how scalable your EMR is. You will need to test those interfaces. You need to have experts who know how to build and maintain them. Don't underestimate go-live support. That will require a lot more individuals than you suspect. Again, this is an area where you can have temporary contracted labor. We used a ratio of, for physicians, 1 support member for every 5 to 8 physicians. Deploy an effective help desk. These individuals will need to be trained in workflows, clinical workflows in multiple areas of your EMR. Their education will likely have to be greater than what your current help desk employees have, and they will need to know how to answer clinical questions as well as technical questions. Tools and technologies that work for your environment. Mobile solutions are the key. Mobile solutions allow you to be more dynamic. It's much easier to swap them out. It's much easier to upgrade. Your physicians, your nurses will demand mobile solutions. Those fixed workstations are dinosaurs. Number 9, define implementation milestones to ensure compliance by 2014 with meaningful use. When you look at your meaningful use project, get a full-time project coordinator, especially for the larger institutions. You need an individual that's going to be able to get the teams together. Have the reports ready when you're building so you know where the data elements are going to fall, and keep a close eye on that. Number 10, consultancies. I'll repeat this. It is going to be impossible for you to hire either internally or externally all of the individuals necessary with all the expertise to do large-scale EMR implementations. Consultants are sometimes very expensive but very necessary part of implementation. Find good ones. Find agencies that have a lot of experience with your particular vendor, and also those that have done large-scale implementations if you have a large hospital. And with that, I will leave time for a question or two.
Angela, can you help us? Were there any questions that have popped up over the last hour that we can have Dr. Paula answer?
Yes, absolutely. Thank you so much. I'll just go ahead and start right in. The first question is about the bylaws. So it says bylaws would require both full-time employee doctors and corp-to-corp doctors to go through the EMR training, correct? And then they said, is this for all on-site personnel?
The particular language that we put in our bylaws was for any physician that was active staff, actively credentialed, had to go through training prior to go live. We differentiated that because there are a number of doctors on our medical staff that have something called a courtesy appointment that do not actively treat patients. So the key word there is active. So if you are going to treat patients in your hospital, you need to have gone through the training before the EMR gets turned on. Yes.
Okay, excellent. Thank you.
We're nearing the end of the time here. Angela, would it be possible for you to send these follow-up questions to Dr. Paula and to James, and then we can include them with the link
Yes, that's fine.
Because I think there's so much great time for content, and I really appreciate both of our speakers. So I want to keep everybody on time, and I think that might be a good way to send those out.
Absolutely, we can do that. And Shelby, then I'm going to go ahead to the next slide if you want to say anything here, and then we'll just wrap it up.
I guess, you know, from a final thought from our perspective, thank you very much to our speakers. You know, we would love the opportunity to partner with our provider organizations out there. From a DISYS perspective, we're providing both staff augmentation and managed project support in the areas of electronic medical implementation services, ICD-10 conversion, and health information technology resources. So we'd love a chance to get to know each of you and see how we can provide support and utilize Dr. Paula and James to help us with providing good solutions. Thank you, Angela, for organizing this. We appreciate your time, and I know you have a few other webinars coming up.
Yes, absolutely. Thanks, Shelby, and thank you to Dr. Paula and James Gaston as well. This was excellent. We even got a comment here that says, excellent presentation, someone who had to sign off already. But just so everyone is aware, again, we will be sending you the webinar recording. There will be a link to the website where we post these so that you can watch it again, or you can pass it along, the link, to someone in your organization who might be needing some help with EMR implementation. Also, we just have some past webinars out there, and I've listed them here. Again, thank you so much, everyone, for your time, and we really appreciate your participation. We really appreciate our presenters who offered some extensive and fantastic knowledge about such a topic that is, you know, really requiring a lot of support today in the healthcare field. So thanks so much, and we hope you have a great day. Thanks. Bye-bye.
Thanks, Angela.
Bye-bye.
Thank you. Thank you. Bye.